Hi everyone, this is a presentation on the Neck Disability Index. So the Neck Disability Index is a questionnaire that is answered by the patient to determine how the patient's daily life is affected by neck pain and is used to assess the patient's self-related disability associated with neck pain. And on the side here we have the actual Neck Disability Index that you would give to the patient and have them answer. So just to start off with a little bit of background on the NDI, Vernon and Mior basically used the foundation of the Oswestry Disability Index, which is directed more towards low back pain, to create the NDI by validating questions that specifically address the neck. And it was created in an outpatient PT department where it was first validated in English, but over time it has been translated and validated in 20 languages, which will be mentioned later in the presentation. The NDI was published in 1991 to assess how neck pain affects activities of daily living in individuals.
Like mentioned before, this questionnaire has been designed to give us information as to how a patient's neck pain is affecting their ability to manage in everyday life. The only items required to take this exam are a copy of the NDI and a pen or pencil. It takes approximately 5 minutes to administer. The questionnaire includes 10 sections or questions that relate to pain intensity, personal care such as washing and dressing, lifting, reading, headaches, concentration, work, driving, sleep, and recreation. Each question contains 6 answer choices and is scored using a numeric rating scale of 0 to 5, 0 meaning no disability and 5 complete disability. All section scores are then totaled. Scoring is reported on a 0 to 50 scale, 0 being the best possible score and 50 being the worst. Alternatively, the score can be reported from 0 to 100. The score is often reported as a percentage. Here you can see the points and percentages and what each means. These are accepted interpretations of the results that people do use out in the clinic, but there's a disagreement and a lack of validity and reliability in this type of interpretation. Minimal detectable change for this exam is 5 points or 10%. NDI changes of 10 points are to be clinically considered meaningful for patients presenting with mechanical neck pain, both with and without concurrent upper extremity symptoms. Originally, no explicit recommendations were made by the developers on handling missing items or minimum number of items required for validity. More recently, it has been suggested that if 3 or more items are missing, the score may not be valid. The intended population for the use of the NDI includes patients with chronic neck pain, musculoskeletal neck pain, whiplash injuries and whiplash-associated disorders, and cervical radiculopathy. The appropriate age range for the NDI should be administered to is 18 years of age and older. It can and has been administered to persons younger than 18, but some of the questions may not be relevant to patients below the age of 18. One consideration might be the potential problem of ceiling and floor effects. If one assumes that the minimal detectable change is usually at 5 points and up to 10 points, then scores of 40 or higher or 10 or lower might be considered problematic for detecting worsening or improvement of neck pain. Another thing to take into consideration is the patient's primary spoken language. The NDI is translated in many languages, such as Greek, German, Dutch, Korean, Spanish, and French. Each has its own validity and reliability outcomes. This is to be taken into consideration because there is an impact of translation on validity.
This slide will discuss the measurement properties of the NDI. Studies suggest that NDI scores tend to be higher for people in their 50s, and that female means tend to be higher too. The cutoff score for the NDI varies considerably depending on whether one uses the MDC or the MCIC, but it tends to be 15 points when detecting neck pain associated with disability. The MDC assesses the minimal magnitude of change required to be confident that the observed change reflects real change and not measurement error. As mentioned previously, this value is usually 5 to 10 points or 10% of the NDI, although numerous studies report changes from 1.7 to 13.4 points. These differences are most likely the result of using different formulas to calculate score and large ranges in standard of measurement. The MCIC is defined as the smallest change that is important to patients. MCIC for NDI has been reported to range from 3.5 to 9. Differences in scores could be the result of several factors such as age, nature and acuity of neck condition, patient setting, baseline scores, treatment, and period of follow-up. Clinicians should be aware of the fact that choosing either the MDC or the MCIC cutoff values gives different values and amounts of certainty on whether the observed change is relevant. By raising the cutoff, the probability of false positives is reduced and the probability of false negatives is increased. Applying the more conservative MDC, the certainty that the change score is relevant and larger than the measurement error is high. The amount of certainty, though, needs to depend on the consequences of patient care and should be a case-by-case decision. This slide will discuss.
So now we come to the evidence for the use of the NDI in various types of neck patients. When looking at validity, reliability, and floor sealing effects, it is important to note that results may differ slightly between studies, although trends do tend to emerge. All of the information contained on this slide is from research studies and is by no means an end-all be-all, so to speak, but is meant to give you an idea for which areas the NDI may be most useful in terms of its use with patients with neck problems. Beginning with validity, it is important to note that criterion validity, including concurrent and predictive validity, construct validity, and content validity, are included on this slide in varying degrees depending on the research study referenced. Here you can see that there are some more specific types of neck problems listed, with the various values for validity included for each. This way you can best classify your patient and determine for yourself if the use of the NDI is beneficial. In looking at this slide, it is important to note the definitions of a few things. The NPQ stands for the Northwick Park Neck Pain Questionnaire. The PET or PET stands for Problem Elicitation Technique. SF6D is a shortened version of the SF36, which stands for Short Form 36 Health Survey. Many of these measures are used in research studies alongside the NDI in order to test for validity. Our values on this slide refer to the correlation coefficient, or the statistical relationship between two variables. On this slide, we see that most R values are considered adequate to excellent, which means that the R values were likely somewhere between 0.5 and 1, relatively speaking, of course. Moving on to our discussion of reliability. Reliability refers to the consistency or repeatability of a test, and here we can see the various values for R and ICC in regards to each neck problem. ICC stands for Intra-Class Correlation Coefficient, and this describes how closely units within the same group resemble each other. It can be thought of as being similar to the R value in this case. Please use the information on this slide as a reference for reliability regarding the NDI. We finally come to our floor and ceiling effects. In simple terms, a floor effect is when most of your subjects score towards the bottom, and a ceiling effect is when most of your subjects score towards the top. In looking at these two research studies at the bottom of this slide, it is important to note that one found no floor-ceiling effects, while the other most definitely did. While research can be conflicting, it can help us to know when to look out for certain things. For example, after reading this information, my main takeaway point would be to watch on the NDI for a majority of your patients either scoring below a 10 or above a 40 to 45, as this is something important to keep in mind.
The NDI does present a few barriers or challenges that we need to keep in mind when we decide to use it for clinical practice. So, for instance, it's restricted to patients older than 18 years old. It does not address psychosocial and emotional factors that have been associated with conditions like whiplash-associated disorder, cervical radiculopathy, and chronic neck pain. It does have a potential floor-ceiling effect that we need to keep in mind. So, for instance, if a patient has initially a high score, it makes it difficult to detect a further disability. Lastly, the questionnaire does not take into account if a patient is taking any medication, and that could have an effect on how they answer the questions on the questionnaire. The clinical bottom line is that there is strong evidence to support the use of the NDI in patients with the following neck conditions: chronic neck pain, musculoskeletal pain, whiplash-associated disorders, and cervical radiculopathy. The APTA ortho section has recognized the NDI to be useful for functional limitation reporting. And to be even more complete, the therapist could add the numeric pain rating scale to that. The NDI has proven to have an adequate to excellent validity with a good test-retest reliability. An area where the NDI could use further research is to determine a set normative data for the scoring of the test, because current research has an accepted set of values that we showed in the chart earlier, but there are studies with differing scores relating to different levels of disability.